The rationale behind it is certainly the same as for conventional provisional, to stabilize and maintain the existing peri-implant soft tissue architecture, but at the same time do not disturb and disrupt the created barrier or the created seal between the abutment and the surrounding tissues. So basically just to minimize the manual interventions. If we look into a case like this, again, only for selected cases, only for cases where we certainly know that we do not need to augment bone previously, where we do not need to go into different surgical approaches, where we can extract the tooth, we have an intact buccal plate, and we can then, after implant installation, if the adequate pre-torque was achieved, we can basically position or adapt a prefabricated zirconia abutment. By using this prefabricated zirconia abutment, we have achieved basically all the requirements we need in regards to biocompatibility of the materials. This is far superior to any acrylic that we have available today, and certainly again the lack of disruption of this interface, so lack or significantly reduced manual interaction. And what we can see here, again as I stated for the first case, whenever we utilize this approach, a subepithelial connective tissue grafting should also be performed just to overcompensate and to increase the thickness and the volume of the soft tissue on the buccal side. But then if the tissues are maturing around these abutments, it is basically then just the question of how the dental technician transfers this. What is the neighboring dentition? How favorable is the neighboring dentition and what can we do? But again, the approach is mostly focusing on creating the tight seal rather than creating a final aesthetic outcome, because as we all know, this is determined by many other factors and should not be considered the sole reason for selecting this approach, because by using a definitive abutment or a provisional abutment, as has been stated in the study where different protocols were compared, the authors found a difference, a significant difference in regards to bone remodeling, but they also stated that the calculated difference of 0.3 millimeters may not necessarily have a clinical impact. So we need to evaluate in prospective long-term follow-up clinical trials if this approach of utilizing the immediate definitive abutment at time of implant insertion is or provides better clinical long-term outcome compared to either a provisional approach where we use an acrylic temporary or even to a two-stage approach. Up to now, we certainly do not have any scientific data on this. Now, the one-stage approach is certainly interesting for many of us and can be applied to some of our patients. However, the clinical reality in many cases is that we do not have, for example, the buccal bone plate present and therefore need to extensively augment hard and soft tissue architecture before we can consider implant placement, before we can consider type of abutment selection. And therefore the conventional two-stage approach, after the implant recipient site has been prepared, after the implant has been placed and time was allowed for healing or for osseointegration, this is certainly still a very reliable treatment approach today. Now, when we select the two-stage approach where we allow for healing, undisturbed healing of the implant, we have several options from a clinical perspective afterwards. So the implant, as you can see in detail in this case, has been inserted. We use a bonded provisional restoration for the healing period. Again, as you can see here on the third image, we overcompensate for the expected tissue remodeling by augmenting tissues at the time point of implant insertion, and then subsequently the image on the right side, you can see the implant after uncovering surgery 10 days following second stage surgery. Now, from a prosthetic perspective, here comes the biggest question, and that is basically how do we proceed? What are our next steps? And in regards to the abutment manufacture, we have basically two two options now. One is to provide the patient with a screw-retained provisional, which we use to contour and shape the peri-implant tissues. That involves that we take an impression, we manufacture the provisional restoration, we have recurrent visits to readjust and adjust the provisional restoration, and finally we can transfer this established contour to the dental laboratory for the manufacture of the definitive abutment.